and we're talking about the rural burden of ill health and the making of a family physician for rural India. Physicians are the natural attorneys of the poor, and a group of us in 1999, that is 16 years ago, we moved from our cities, from where we had our medical school training, and then went to the central part of India in Chhattisgarh, with the basic objectives of providing service both at the clinic level and in the community, learning from problems that we faced, and using force multipliers of training, research, and advocacy. This is the central part of India where we started our work in Chhattisgarh, the seahorse-shaped state. And the terrain is difficult. This is essentially a forested area. A large part of it is cut off when there are rains because of the seasonal rivers. And this is how patients are often brought up to the road head. This is the intensive work area, which is essentially forest and forest-fringed villages. Our health center is located here in a village which is 25 kilometers from Bilaspur town, and the community program area is located further north 50 to 70 kilometers in this forested area. 2,500 villages access the referral center, and 175 forest and forest-fringed villages access the mobile clinics which are located within the program area. The program area consists of 70 villages and caters to a population of 32,500. This is a view of the outpatients, which is a very busy OPD, usually seeing about 350 to 400 patients in a given day. And this is a view of the inpatients. We have a 70-bedded inpatient facility, an extremely busy laboratory, the operation room. The complexity of the problems that one sees: a young man with pulmonary tuberculosis presenting with respiratory failure required oxygen for almost 12 days before we could wean him off. Or this family of three, all three of whom had pulmonary tuberculosis at the same time, the father, the son, and the daughter. Or this baby with sickle cell dactylitis. Or this young man with a nerve abscess following leprosy. Or this baby who fell into a fire because his mother had uncontrolled leprosy. Or this woman with obstetric fistula. A newborn with intestinal obstruction. A baby with a necrotizing fasciitis, a very severe, unfortunate type of necrotizing fasciitis. A woman with obstructed labor and hand prolapse. Or this gentleman who had a severe post-burn contracture of several years' duration. A woman who had a breast tumor with pregnancy. Or these patients, this lady who had an extensive oral cancer, or this baby who had a rhabdomyosarcoma. These three children who had delayed presentation of their pneumonias and then developed empymas, all of them requiring decortication at the same time. So what we realized when we went to this rural part of India was that people in small places do not have small problems, and thus they require significant technical and social expertise. And beyond the types, the complexity of the illnesses is the dilemma of the people and the quality and the humanity of services that is required. There are, of course, these exotic illnesses which are there in rural areas, especially in forested areas: bites due to snakes, rabid animals, stings due to scorpions, bees, and wasps. Occupational illnesses because of laboring in the fields, necrotizing fasciitis, infective keratitis due to paddy husk, onychomycosis in the males, silicosis because they are either working in brick kilns or stone crushing. Lifestyle of poverty leading to rheumatic heart disease, low body weight diabetes, and chronic lung failures. Diseases which are because of poor access to healthcare, contractures following burns, trauma, urethral strictures because of infection, trauma, and they could present with renal failure. Margolins, ulcers, severe anemias because of simple problems like piles which are bleeding, or menorrhagia or worm infestations. Obstetric fistulas, urinary calculus leading to renal failure, BPH leading to renal failure because of UTIs, deep abscesses, and osteomyelitis. This young man, 16-year-old, had this urethral stricture for almost a year. He was roaming around with this catheter in place, or this osteomyelitis. And then, of course, the mundane problems, falling off trees. You may have a spine injury, you can have a head injury, drowning, electrocution, lightning strikes, sickle cell disease, multi-organ failure, and severe falciparum malaria. You name it, and everything that one sees in a tertiary care setup in a medical college, you have it there. So the huge burden of illnesses that one sees, we saw over 400 cases of tuberculosis, of cancers, of hypertension, of diabetes, illnesses requiring major surgery 1561, sickle cell disease 115, leprosy 100. All of these are new cases which are seen in 1 year. Rheumatic heart disease 64. So what's special to rural healthcare? There are more complex problems, both because of deprivation and because of poor access. There is a larger direct evidence of economic and social determinants and lesser human and infrastructure resources. Massive levels of hunger, what we in a sanitized form call undernutrition, massive levels of morbidity and a vast unmet need for curative healthcare, and thus a high number of premature deaths and a marginalization and trivialization of their problems. So primary healthcare, what it is not, is it is not just primary level care. In the rural parts, in the rural hinterland where 70% of our population stays, it's not second-rate medicine for the have-nots. And it should not be straight-jacketed, trivialized protocols and regimes for these people. This Virchow had said many years ago, illnesses are biological embodiments of deprivation. These are the kinds of surgical problems that we saw in our primary care setup. Soft tissue infections, calculus disease, cancers which needed operations, prostatic surgeries, fibroid uterus and menorrhagia, life-saving emergency surgeries, pediatric surgery, because I'm a pediatric surgeon, so this is a large number, post-burn contractures, empyremas, and there are all these. This is from our area, the community burden of selected illnesses in adults, and one can see all the common illnesses, asthma, cancers, all of these are manifest in this area. And of course there is malaria, there is hypertension, there is peptic ulcer disease and a severe anemia. Illnesses in the community in the young, these are all listed out here. The numbers, we have seen 350,000 new patients till date, 640,000 consultations have been done. 1.3 million population accesses the referral center at Ganyari from 9 districts and 2,500 villages, and a total of 21,000 surgeries have been performed till date. How does one make low-cost care possible in these settings? By systems modification, reducing the cost of diagnosis, reducing the cost of drugs, developing appropriate management protocols, and most importantly, training local manpower and developing a team. And in developing this team, it's very important that the leaders of this team are despecialized doctors with multi-skilling. Because what do you do if you're asked to manage a snake bite patient with neck muscle weakness, or apply a figure of 8 bandage in a clavicular fracture, read a thick blood smear, advise parents of a 1.8 kg child for home-based care, or manage 3 cases of severe malaria coming from the same village 50 kilometers from the nearest town, or manage a woman who's bleeding profusely after delivery and has a firm contracted uterus, manage a child who's unconscious after falling from a tree, or do a sputum AFB stain, or manage an alcoholic who beats his wife regularly and is coming sober now, or respond sensitively to a woman who's been accused of sorcery with witchcraft by her village. So one needs to have a lot of competences and also basic lab skills in reading a blood smear or for malaria or sputum for AFB, urine microscopy and routine check, hemoglobin, total and differential leukocyte counts, ESR, blood grouping, stool for ova and occult blood, sample collection and transportation. And of course, knowledge and attitude skills, when to treat, when to refer, if to refer, how does one plan referral, emergency management and abandonment management, chronic disease and follow-up care, and of course home-based care. So it all translates into a much better diagnostician, very skilled in emergency management, a skillful communicator and on-the-job learner, specially skilled to understand the socio-economic predicament of the people. So this elusive generalist, what in India we call as the Kishore Kumar. He's a film director, he's a musician, he writes the songs, he writes the script, and he can do everything. So this is what we need in India, for rural India. So the making of a family physician. How do we nurture curiosity and creativity so that they are able to ask and try to solve difficult questions beyond the clinical questions, and teach them to touch each patient tenderly with our hands and words with utmost respect and reverence. So our role should be essentially to inspire and coach rather than preach and teach. To unmarginalize or demarginalize rural medicine, one needs to specialize in general medicine and celebrate general medicine, generalism. Get virtuoism in, and one needs to take training out of tertiary specialty setups. It should not be the proverbial Indian elephant where each one learns how to feel the tail or the trunk or the legs or the tusks, but doesn't know what the entire elephant looks like. And appropriate use of information technology and making these available and resources, good resources available so that they can be self-directed learning is possible. And tacit knowledge transfer, of course, is there. Thank you.
Thanks a lot, Dr. Raman. It was really a very comprehensive presentation. And I hope that we somehow learn to associate social determinants of health with actual morbidity. So if anybody has any questions.
Thank you, Amanda Howe from the UK. Thank you so much for that presentation. That was a big reminder to me of the clinical issues that you and your team have to face, and respect for that. My two questions are, do you now have any young doctors training with you so that, as you say, we need to be training people outside? Do you have this opportunity? I saw one group that I would, like to know a little bit more about that. And also you used the words marginalisation, trivialisation. And I think you didn't mean by the people about themselves, you meant by the system about that system. Yeah, thank you. So who do you train? It's residents, right?
Yes, so we fortunately now got family medicine residents. Many of them are sitting here behind you.
Hello.
So, we're really excited because of this, and I think they're equally excited also being in our place. And this has been on for the last 1.5 years now.
Students from the medical schools? Not yet.
So, some students have been visiting off and on from some medical schools, but not on a regular basis.
That's it. Anyone else? Thank you so much. Thanks a lot. Now I invite Dr. Pavitra Mohan, who will give his presentation on experiences from rural Rajasthan.